Urology and fluid electrolyte and acid-base balance. So as a review of the urinary system contains 6 primary organs. There's 2 kidneys, 2 ureters, the urinary bladder, and urethra. So the kidneys are where urine is produced. The ureters is where urine is transferred from the kidneys down to the urinary bladder. The urinary bladder stores urine for later release, and the urethra is the tube that leads out of the body. The urethra is larger in the male versus the female, and this is why females are more likely to develop UTIs. So this is a picture, a diagram of the kidneys, the ureters, urinary bladder, and urethra. Functions of the kidneys: to filter blood and excrete toxic metabolic wastes. So any toxins that are in the blood or anything that's not needed in the blood, or to help regulate the fluid, electrolyte, and acid-base balance of the blood, we can excrete stuff out through the kidneys. Regulate blood volume, pressure, and osmolarity. Regulate electrolytes and acid-base balance, like I just mentioned. Secrete erythropoietin, which stimulates the production of red blood cells. Help regulate calcium levels by participating in calcitrol synthesis. Clear hormones from the blood. Detoxify free radicals. In starvation, they synthesize glucose from amino acids. So waste is any substance that's useless to the body or present in excess of the body's needs. Metabolic waste are waste substances produced by the body. Among the most toxic are nitrogenous wastes. They're called nitrogenous because they contain nitrogen. Urea is from protein catabolism. So we break down proteins, we break it down into ammonia, which then gets converted to urea through the urea cycle. If we were to allow it to stay as ammonia in the body, ammonia is highly toxic and we would die very quickly. So, good thing this urea cycle exists. Uric acid is a product of nucleic acid catabolism, and creatinine is a product of creatine phosphate catabolism. Blood urea nitrogen is the level of nitrogenous waste in the blood, so it takes into account all of those. Normal concentration of blood urea is 10 to 20 mg per deciliter. Azotemia is an elevated BUN. It may indicate renal insufficiency. Azotemia may progress to uremia, which is a syndrome of diarrhea, vomiting, dyspnea, and cardiac arrhythmia that's stemming from the toxicity of nitrogenous wastes. Excretion, separating wastes from body fluids and eliminating them, is carried out by 4 main body systems. The respiratory system: carbon dioxide is excreted and other small amounts of other gases and water. Integumentary system: water, inorganic salts, lactate, and urea in the sweat. Digestive system: water, salts, carbon dioxide, lipids, bile, pigments, cholesterol, and other metabolic waste. And undigested food is disposed of. Urinary system: many metabolic wastes, toxins, drugs, hormones, and salts. Hydrogen ions and water. The basic stages of urine formation are as follows. First, we have glomerular filtration. So inside of the kidneys, and this is a review, the kidneys contain all of these little independent functional units called nephrons. And a nephron consists of a ball of capillaries that's super leaky, and pretty much everything smaller than a red blood cell can leak out of the capillaries. Then it contains a catcher's mitt, or a catching device called the Bowman's capsule that surrounds that, so that anything that falls out of the bloodstream in that location gets caught by that Bowman's capsule. Then we send it on a pathway of reabsorption. So basically what happens is everything falls out of the blood, and then the kidneys, or the nephron tubules, decide what still needs to stay in the body. So we reabsorb all the good stuff and leave the bad stuff to pass through to the urine. So we have tubular reabsorption that removes the useful solutes from the filtrate and returns them to the blood. Tubular secretion is when we remove additional waste from the blood and force them into the urine. And water conservation removes water from the urine and returns it to the blood and concentrates wastes. Glomerular filtration: water and some solutes pass from the blood within the glomerulus to the capsular space of the nephron. The filtration membrane is the barrier through which filtered fluid passes, and it contains 3 components. This should be a review for the most part from general EMPs, so you won't be tested on these individual components. They're listed here for your review. Almost any molecule smaller than 3 nanometers can pass freely through the filtration membrane. Water, electrolytes, glucose, fatty acids, amino acids, nitrogenous wastes, and vitamins. Some substances of low molecular weight are bound to plasma proteins and they can't get through the membrane. Most calcium, iron, thyroid hormone, unbound fraction passes freely into the filtrate. In kidney infections, trauma can damage the filtration membrane and allow proteins, blood cells, to filter through. Proteinuria, or albuminuria, albumin in the urine, and hematuria is when you have blood in the urine. So this shows the glomerular filtration membrane. You can pause and take a look at the diagram. Glomerular filtration depends on the same principles governing filtration in other capillaries. Blood hydrostatic pressure, 60 millimeters mercury. It's high in glomerular capillaries because of afferent arteriole is larger than the efferent arteriole, a large inlet and small outlet. Hydrostatic pressure in the capsular space, 18 millimeters mercury, due to high filtration rate and accumulation of fluid in the capsule. Colloid osmotic pressure of the blood, 32 millimeters mercury. Glomerular filtrate is almost protein-free, no significant COP. Net filtration pressure is the balance of those forces. So 60 out, minus 18 in, minus 32 in is 10 millimeters outward. And this diagrams that pressure. So COP stands for colloid osmotic pressure. BHP is the blood hydrostatic pressure. CP is the capsular pressure. And then you have net filtration pressure. And the net filtration pressure is the pressure that forces the solution through that nephron tubule. The glomerular filtration rate is the amount of filtrate formed per minute by the two kidneys. The total amount of filtrate produced per day equals 50 to 60 times the amount of blood in the body. 99% of filtrate is reabsorbed since only 1 to 2 liters of urine are excreted per day. The glomerular filtration rate must be precisely controlled. If it's too high, fluid flows through the renal tubules too quickly for them to be reabsorbed, and we lose a lot of nutrients in our urine. Urine output rises and increases the chance of dehydration and electrolyte depletion. If the glomerular filtration rate is too low, wastes are then reabsorbed, and azotemia may occur. The only way to adjust GFR from moment to moment is to change the glomerular blood pressure, and that occurs through 3 mechanisms: renal autoregulation, sympathetic control, and hormonal control. Renal autoregulation is the ability of the nephrons to adjust their own blood flow and GFR without external nervous or hormonal control. It enables the kidneys to maintain a relatively stable GFR in spite of changes in arterial blood pressure. So even if our blood pressure goes through the roof for whatever reason, or if it drops down super low, our glomeruli have the ability to control their own destiny. 2 mechanisms of autoregulation: myogenic mechanism and tubular glomerular feedback. The myogenic mechanism, stabilizing GFR, is based on the tendency of smooth muscle to contract when stretched. If arterial blood pressure increases, the afferent arteriole is stretched, and then it constricts as a reflex to prevent blood flow into the glomerulus from changing. If the arterial blood pressure falls, the afferent arteriole relaxes, and then it dilates and allows blood flow more easily into the glomerulus, so that flow rate remains the same and filtration remains stable. The tubuloglomerular feedback: the glomerulus receives feedback on the status of downstream tubular fluid and adjusts filtration rate accordingly. It regulates filtrate composition, stabilizes kidney performance, and compensates for fluctuations in blood pressure. It involves the juxtaglomerular apparatus, a complex structure found at the end of the nephron loop where it has just re-entered the renal cortex. Ascending nephron loop comes in contact with the afferent and efferent arterioles at the vascular pole of the renal corpuscle. It involves macula densa cells of the nephron loop and granular cells of the afferent arteriole. And this is a diagram of that structure. So if we have a high GFR, we increase sodium chloride load in the nephron loop. The macula densa secretes ATP, which the mesangial cells metabolize ATP to adenosine. Adenosine stimulates granular cells. The afferent arteriole constricts, and it reduces the glomerular filtration rate. Sympathetic control. So we talked about sympathetic, the fight or flight response, and parasympathetic, the rest or digest response. So if the sympathetic nervous system is stimulated, we do not want our body to produce urine. We want all of our actions and activities and energy to be switched toward preparing our body for a fight or to run away from something. Sympathetic nerve fibers richly innervate the renal blood vessels. Sympathetic nervous system and adrenal epinephrine constrict the afferent arterioles in strenuous exercise or acute conditions like circulatory shock. It reduces the GFR and urine output, redirects blood from the kidneys to the heart, brain, and skeletal muscles. The GFR may be as low as a few milliliters per minute. So now we're going to talk about the hormonal control of glomerular filtration. The renin-angiotensin-aldosterone mechanism. This is a system of hormones that controls blood pressure and glomerular filtration rate. In response to a drop in blood pressure, baroreceptors in the carotid and aorta, so the carotid artery and aorta, stimulate the sympathetic nervous system. Sympathetic fibers trigger the release of renin by the kidney's granular cells. Renin converts angiotensinogen, a blood protein, into angiotensin 1. The lungs and kidneys have angiotensin-converting enzyme, ACE, that then converts angiotensin 1 to angiotensin 2. Angiotensin 2 is a hormone that acts in several ways to restore fluid volume and blood pressure. So what I recommend doing is you definitely need to know the renin or the RAS system, renin-angiotensin-aldosterone system. So I recommend just drawing like a little flow chart of kidneys, arrow, renin. Renin is the intermediary that converts angiotensinogen from the blood into angiotensin 1. Then we have lungs and kidneys that have ACE, and that converts 1 to 2. If you've ever heard of ACE inhibitors before, ACE inhibitors are sometimes prescribed to people with high blood pressure. What an ACE inhibitor does is it inhibits the angiotensin converting enzyme. That means that this system that's responsible for stimulating the aldosterone to retain more sodium, which retains more water, which increases your blood pressure, it stops that system from happening so that your blood pressure can be a bit lower because you're going to be losing a lot more fluid through the urinary system instead of retaining it. The effects of angiotensin 2, it's a potent vasoconstrictor. It raises blood pressure throughout the body. Constricts efferent arterioles in kidneys, raising GFR despite low blood pressure. Constriction of efferent arterioles lowers blood pressure in peritubular capillaries, enhancing reabsorption of sodium, chloride, and water. It stimulates the adrenal cortex to secrete aldosterone, which further promotes water reabsorption in the distal collecting tubule and collecting duct. It directly stimulates sodium and water reabsorption in the primary convoluted tubule. Stimulates posterior pituitary to secrete antidiuretic hormone, which promotes water reabsorption by the collecting duct and stimulates thirst and encourages water intake. You should be familiar with all of these different functions of angiotensin 2 and how ACE inhibitors will then help to decrease blood pressure. Here's a diagram of this process, so I recommend pausing the video and reviewing it. So moving on, we've got the glomerulus. We've learned about the filtration rate at the glomerulus. So all this stuff is going to leak out of the glomerulus, and it's highly regulated with the speed at which it can leak out. Surrounding the glomerulus is a Bowman's capsule. It's basically just like a bowl, and it's going to capture everything that leaks out. Then it sends the fluid or the filtrate down through the tubules. And the first part along the way is the proximal convoluted tubule. This reabsorbs about 65% of the glomerular filtrate. Also removes substances from the blood and secretes them into tubular fluid for disposal in the urine. A prominent role in absorption secretion reflected in its structure and energy consumption. So all sorts of different types of nutrients are reabsorbed in this location. So sodium, glucose, hydrogen, chloride, anions, water, all sorts of stuff. Urea passes through the epithelium with water. Nephron reabsorbs about half the urea in tubular fluid. The concentration remaining in the blood is safe. The primary convoluted tubule reabsorbs nearly all uric acid, but later proportions of the nephrons secrete it. Creatinine is not reabsorbed, it's passed in the urine. Each day, the kidneys reduce 180 liters of glomerular filtrate to 1 or 2 liters of urine. Most of this is due to water reabsorption. 2/3 of the water in the filtrate is reabsorbed in the primary convoluted tubule. Reabsorption of solutes makes the tubule cells and tissue fluid hypertonic to the tubular fluid. Water then flows by osmosis. Transcellular absorption via water channels called aquaporins also happens. In the primary convoluted tubule, water is reabsorbed independent of hormones at a constant rate called the obligatory water reabsorption. Uptake by the peritubular capillaries. The peritubular capillaries reabsorb water and solutes that leave the basal surface of the tubular epithelium. Reabsorption occurs by osmosis and solvent drag. In other words, water goes, solutes follow. 3 factors promote osmosis in the capillaries: high interstitial fluid pressure due to the accumulation of reabsorbed fluid in the extracellular space, low blood hydrostatic pressure in peritubular capillaries due to narrowness of efferent arterioles, further accentuated by action of angiotensin II, and high colloid osmotic pressure in the blood due to the presence of proteins that were not filtered. And here is the effect of angiotensin II on tubular reabsorption. You can pause the video and read through this diagram. The transport maximum. This is the maximum rate of reabsorption for an individual solute, which is reached when all transport proteins are saturated. If transporters are occupied, any excess solute passes by and appears in the urine. Transport maximum is reached when transporters are saturated. So each solute has its own transport maximum. Example, any blood glucose level above 220 mg per deciliter results in glycosuria, and that's glucose in the urine. Glucosuria is a classic sign of untreated diabetes mellitus, where plasma glucose may exceed 400 mg per deciliter. If you've got glucose coming out in the urine and you're pregnant, it could indicate gestational diabetes. So if you do end up getting pregnant, or if you were pregnant in the past, or if you know someone that's been pregnant, they go to the doctor. Every time they go to the doctor, they do a urine test. And you may be wondering, like, why are you testing my urine? You know that I'm pregnant. So are you giving me another pregnancy test? No. Maybe they may be monitoring levels of HCG, but levels of HCG tend to drop off a little bit, and then we don't really care so much about HCG to maintain the pregnancy. Progesterone is our hormone that maintains the pregnancy, which we'll learn about next time. But what they're looking for is the presence of urine or protein, glucose or protein in the urine. If there's glucose in the urine, you may be developing gestational diabetes. If there's protein in the urine, you may be developing preeclampsia or high blood pressure, which can elevate the blood pressure to a point where it starts to cause proteins to leak out in the urine. So those are complications that can occur during pregnancy. You can pause the video and review this diagram. Tubular secretion is different from tubular reabsorption. So reabsorption is when the stuff falls out of the glomerulus, and now your tubules are going to suck back up the stuff that we need in the body. Secretion is when the tubules force excess substances into the urine, sometimes against their concentration gradient. The purpose of secretion in the primary convoluted tubule and nephron loop include acid-base balance, waste removal, and the clearance of drugs, contaminants. Sometimes there's toxins that we need to remove from bacterial infections and so forth. The nephron loop's primary function is to generate the osmotic gradient that enables the collecting duct to concentrate the urine and conserve water. The thick segment reabsorbs 25% of the sodium, potassium, and chloride ions in the filtrate. Ions leave by active transport and diffusion. Sodium chloride remains in the tissue fluid of the renal medulla. Water cannot follow since the thick segment is impermeable to water. The tubular fluid is very dilute as it enters the distal convoluted tubule. Fluid arriving in the distal convoluted tubule still contains about 20% of the water and 7% of the salts from the glomerular filtrate. If this were all passed as urine, it would amount to 36 liters per day. The distal collecting tubule and collecting duct reabsorb variable amounts of water and salt and are regulated by several hormones: aldosterone, atrial natriuretic peptide, antidiuretic hormone, and parathyroid hormone. Aldosterone. So this is a steroid hormone that stimulates the reabsorption of sodium and secretion of potassium. Sodium and potassium are both positively charged. We've learned in the past about how like charges repel each other. So if you reabsorb sodium, you're not also going to reabsorb potassium. That's too much positivity in one area. So sucking in sodium pumps out potassium. Sodium and potassium typically move in opposite directions. We also learned about sodium and potassium in the nerve impulse, and they did the same thing. Salt retaining hormones. So it's secreted by the adrenal cortex. The triggers for aldosterone secretion are blood sodium concentration declines or potassium concentration rises. A drop in blood pressure stimulates renin release, which ultimately leads to aldosterone secretion. It acts on the thick segment of the ascending nephron loop on the distal collecting tubule and the cortical portion of the collecting duct. It stimulates the reabsorption of water or sodium and the secretion of potassium. So sodium in, potassium out. Water and chloride ions are then going to follow the sodium. The net effect is that the body retains salt and water. It helps to maintain blood volume and pressure. Urine volume is reduced. Urine has an elevated potassium concentration. Natriuretic peptides are secreted by the heart in response to high blood pressure. Their goal is to make you pee more so that your blood pressure drops. So it results in the excretion of more salt and water in the urine, thus reducing blood volume, which decreases blood pressure. It dilates the afferent arteriole, constricts the efferent arteriole to increase glomerular filtration rate. It inhibits renin and aldosterone secretion and inhibits secretion of antidiuretic hormone. It inhibits sodium chloride reabsorption by the collecting duct. The antidiuretic hormone. A diuretic or diuresis is the passing of urine or losing of fluid. Antidiuretic hormone. Antidiuretic would mean that you're not losing fluid, you're retaining fluid. So this stimulates water retention by the kidneys. Dehydration, loss of blood volume, and rising blood osmolarity stimulate the arterial baroreceptors and hypothalamic osmoreceptors. Now, when we talk about osmolarity is the concentration of stuff inside of a solution. So whether it's ions or if it's like electrolytes or if it's non-electrolytes, it's the concentration of junk that's in a solution. In a solution, you've got the solute and the solvent. The solute is the stuff. The solvent is usually something that's liquid like water, or sometimes alcohol can be used as a solvent when we're talking about like chemistry. Not the alcohol you drink, but alcohol like ethanol in chemistry. So when we talk about an increase in blood osmolarity, that means that there's a lot of stuff and not a lot of fluid in your blood. Triggers the release of ADH from the posterior pituitary. ADH makes the collecting duct more permeable to water. Water in the tubular fluid re-enters the tissue fluid and bloodstream rather than being lost in the urine. Parathyroid hormone is secreted from the parathyroid glands in response to a calcium deficiency or hypocalcemia. It acts on the primary convoluted tubule to increase phosphate excretion. It acts on the thick segment of the ascending nephron loop and on the distal collecting tubule to increase calcium reabsorption. Increases phosphate content, lowers calcium content in the urine. Because phosphate is not retained, calcium ions stay in circulation rather than participating into bone tissue, or precipitating into bone tissue as calcium phosphate. Parathyroid hormone stimulates calcitrol synthesis by the epithelial cells of the PCT. The collecting duct can produce a hypertonic urine. The collecting duct begins in the cortex where it receives tubular fluid from several nephrons. It runs through medulla, reabsorbs water, making urine up to 4 times more concentrated. The medullary portion of the collecting duct is more permeable to water than salt. As urine passes through the increasing salty medulla, water leaves by osmosis, concentrating the urine further. And this shows that happening. So as the osmolarity of the tissue increases, water is encouraged to be reabsorbed more and more and more. The control of water loss. So how concentrated the urine becomes depends on the body's state of hydration. Dehydration leads to the production of hypertonic urine. ADH stimulates increase in aquaporin channels in the collecting duct, and more water is reabsorbed, resulting urine is scanty and more concentrated. When well hydrated, urine is less concentrated. ADH secretion falls, tubule cells remove aquaporins, the collecting duct is less permeable to water, so more water remains in the duct, resulting in urine is more abundant and dilute. The countercurrent multiplier. This is the mechanism by which the nephron loop continually recaptures salt and returns it to the medulla. The ability of the kidney to concentrate urine depends on the salinity gradient in renal medulla. It's 4 times more salty in the renal medulla than the cortex. Nephron loops acts as a countercurrent multiplier. It's called a multiplier because it multiplies the osmolarity of the adrenal medulla. It's called a countercurrent mechanism because fluid flows in opposite directions in adjacent tubules of the nephron loop. Fluid flowing downward in the descending limb passes through an environment of increasing osmolarity. Most of the descending limb is very permeable to water, but not to salt. Water passes from the tubule into the extracellular fluid, leaving salt behind. This concentrates tubular fluid to a higher amount at the lower end of the loop. Fluid flowing upward in the ascending loop is impermeable to water and reabsorbs only the ions by active transport pumps into the extracellular fluid. This maintains high osmolarity of the renal medulla. Tubular fluid becomes more dilute at the top of the loop. Recycling of urea adds to the high osmolarity of the deep medulla. Lower end of the collecting duct is impermeable to urea, but neither the thick segment loop or the DCT is permeable to urea. Urea is continually cycled from the collecting duct to the nephron loop and back. Urea remains concentrated in the collecting duct, and some of it always diffuses out into the medulla, adding to osmolarity. So this is a diagram of what I just discussed. You should go ahead and pause the video and read through this diagram. The countercurrent exchange system. It prevents dilution of the medulla osmolarity gradient. The vasa recta carry away water reabsorbed by the collecting duct. The countercurrent system ensures that salts, urea, are not also carried away from the medulla. Countercurrent system formed by the blood flowing in opposite directions in adjacent parallel capillaries. The descending capillaries of the vasa recta exchanges water for salt. Water diffuses out of the capillaries and salt diffuses in. Ascending capillaries of the vasa recta exchanges salt for water. Water diffuses into and sodium diffuses out of the blood. The vasa recta gives the salt back and does not subtract from the osmolarity of the medulla. And here's a diagram of that, and you can see the arrows of movement in the different regions. And here's another diagram that you can pause and review. So urine and renal function tests. So urinalysis is the examination of physical and chemical properties of the urine. First, we look at the appearance. It should be yellow in color, but it varies from clear to deep amber depending on the state of hydration. Yellow color is due to urochrome pigment from the breakdown of hemoglobin. Cloudiness or blood could suggest a urinary tract infection, trauma, or stones, or it might be just contamination with other fluids. Pyuria is pus in the urine, and hematuria is blood in the urine, sometimes due to a urinary tract infection, trauma, or kidney stones. Odor: bacteria degrade urea to ammonia. Some foods and diseases impart particular aromas. Specific gravity is the relative density of a substance to that of water. The density ranges are listed. Osmolarity ranges as listed. That tells you that in combination with specific gravity tells you the overall hydration of the patient. pH ranges from 4.5 to 8.2. Usually it's about 6, mildly acidic. The chemical composition is listed here. It would be abnormal to have glucose-free hemoglobin, albumin, ketones, or bile pigments in the urine. Normal urine volume is 1 to 2 liters per day. Diuresis or polyuria is an output of excess of 2 liters per day. Oliguria is an output of less than 500 mils per day. And anuria is 0 to 100 mils per day. Low output from kidney disease, dehydration, circulatory shock, prostate enlargement. Low urine output of less than 400 mils per day. The body can't maintain safe, low concentration of waste in the plasma, and that leads to azotemia. Diabetes: any metabolic disorder resulting in chronic polyuria. So diabetes type 1 and 2 are listed, and diabetes insipidus. Basically, increased thirst, increased urination. Diuretics: any chemical that increases urine volume. Some increase the glomerular filtration rate, and some reduce tubular reabsorption of water. Loop diuretics act on a nephron loop and inhibit ion symport. It impairs the countercurrent multiplier. Collecting duct is unable to reabsorb as much water as usual. It's commonly used to treat hypertension and congestive heart failure by reducing the body's fluid volume and blood pressure. So now that we learned a little bit about how the body retains water and regulates the amount of water in the bloodstream, I'm going to talk a little bit about fluid balance. Body water percentage varies based on your age. So newborn baby's body weight is about 75% water. Total body water content of an average young adult is 60% men and 50% women. Why is it less in women? Because women tend to have more fat in their bodies, and the more fat, the less water is stored. Men tend to have more muscle mass in their bodies, so more muscle can accommodate more water. Obese and elderly people are as little as 45% by weight. The fluid compartments are areas separated by selectively permeable membranes and differing in chemical composition. The major fluid compartments of the body are 65% intracellular fluid, or inside of the cells, and 35% extracellular fluid. Extracellular fluid is divided into 25% tissue fluid, so the fluid between the cells of the tissues, 8% blood plasma and lymph, and 2% transcellular fluid. CSF, synovial, peritoneal, pleural, pericardial fluids, vitreous and aqueous humors of the eye, fluids of the digestive, urinary, and reproductive tracts. Fluid is continually exchanged between compartments. Intracellular and extracellular osmolarity are equal because water moves easily through membranes. Osmotic gradients never last long. If imbalance arises, osmosis restores the balance within seconds. Osmosis from one fluid compartment to another is determined by the relative concentrations of solutes in each compartment. Most solute particles are electrolytes, sodium salts in ECF, potassium salts in ICF. Electrolytes play the principal role in governing the body's water distribution and total water content. When daily water gains and losses are equal, we have fluid balance. Gains come from two main sources: metabolic water and preformed water. So metabolic water is formed by aerobic metabolism and dehydration synthesis. Preformed water would be ingested in food and drink. Routes of water losses are more varied. Urine, feces, expired breath, sweat, cutaneous transpiration, the water that diffuses through the epidermis and evaporates. Insensible water loss, you're not usually aware of it. Breath and cutaneous transpiration. Sensible water loss, you are noticing that you're losing water, so urine and moderate sweating. And obligatory water loss, output that is unavoidable, so expired air or feces. And here's a diagram that shows those. Fluid intake is governed mainly by the sense of thirst. Conditions that lead to thirst: dehydration reduces blood volume and blood pressure, increases blood osmolarity. Osmoreceptors respond to angiotensin II and rising osmolarity of ECF. ADH release by the hypothalamus promotes water conservation and stimulates the cortex to provide a sense of thirst. Salivation also inhibited, leading to dry mouth. Long-term inhibition of thirst, absorption of water from the small intestine reduces the osmolarity of the blood. It stops the osmoreceptor response, promotes capillary filtration, and makes saliva more abundant and watery. Here's a diagram that you can kind of follow the path through. Regulation of output. So the only way to control water output significantly is through variation in urine volume. Kidneys cannot replace water electrolytes. They can only slow the rate of water and electrolyte loss until water and electrolytes can be ingested. Changes in urine volume are linked to adjustments in sodium reabsorption, and water follows the movement of sodium. ADH provides a means of controlling water output independently of sodium. And here's a diagram that you can review. Disorders of fluid balance. So fluid deficiency, a fluid imbalance that arises when fluid output exceeds intake over long periods of time. Two types of deficiency: volume depletion and dehydration. Volume depletion, or hypovolemia, is proportional amounts of sodium and water are lost without replacement. Total body water declines, but osmolarity remains normal. Caused by hemorrhage, burns, chronic vomiting or diarrhea, aldosterone hyposecretion, such as Addison's disease. Dehydration, or negative water balance, the body eliminates significantly more water than sodium. Extracellular fluid osmolarity rises, caused by lack of water intake, diabetes mellitus, diabetes insipidus, profuse sweating, or overuse of diuretics. There are some individuals that think that if they use diuretics, they lose a lot of weight, and they do lose some water weight. But as soon as they take a drink, their body wants to reach homeostasis, and they gain all that water weight back. So the use of diuretics is definitely not a thing that should be done to lose weight. Dehydration affects all fluid compartments. So example, water loss from sweating. Sweat produced by capillary filtration, blood volume and pressure drop, osmolarity rises. Blood absorbs tissue fluid to replace the loss. Tissue fluid is pulled from the intracellular fluid. The blood, intracellular fluid, and tissue fluid all lose water. For 1 liter of sweat, 300 mils from tissue fluid and 700 mils from ICF are drawn. And here's a diagram that shows that process. Fluid excess is much less common than fluid deficiency because kidneys are highly effective in compensating for excess intake by excreting more urine. But there's two types of fluid excess: volume excess and hypotonic hydration. Both sodium and water are retained and the ECF remains isotonic. It's caused by aldosterone hypersecretion or renal failure. Hypotonic hydration, or water intoxication, also known as positive fluid balance. More water than sodium is retained or ingested, and the extracellular fluid becomes hypotonic. Causes losing large amounts of water and salt through urine and sweat, but replace it by drinking only plain water. Water dilutes the extracellular fluid, making it hypotonic, and that leads to cellular swelling and dysfunction. So if you drink a ton of water, you can have water intoxication, and that can be deadly. So it's important that If you are doing strenuous exercise, instead of just drinking pure water, you drink something with electrolytes in it for a balance. And this shows the relationship of blood volume to fluid intake. Fluid sequestration, excess accumulation of fluid in a particular location. Total body water and osmolarity may be normal, but circulating blood volume may drop and low enough to cause circulatory shock. Edema is an accumulation of fluid in the interstitial spaces. It's the most common form of fluid sequestration. Hemorrhage can cause fluid sequestration as blood pools and clots in the tissues. Pleural effusion, fluid accumulation in the pleural cavity, caused by some types of lung infections. So moving on to electrolyte balances. So electrolytes are ions that have a charge. You can see you've got sodium Na with a plus, Na plus, K plus, Ca2 plus, so that's potassium, calcium, magnesium, hydrogen, and then you have anions which have a negative charge, so that's chloride, bicarbonate, and phosphate. The amount of electrolytes absorbed by the small intestine balances the amount lost from the body in the urinary system. The physiological importance of electrolytes, chemically reactive and participate in metabolism, determine electrical potential or charge difference across cell membranes, strongly affect the osmolarity of body fluids, and affects the body's water content and distribution. There are significant differences between electrolyte concentrations of blood plasma and intracellular fluid. And we learned about that when we talked about the nervous system. So like I said, we've got more sodium on the outside of cells, more potassium on the inside of cells, more chloride in the outside of the cells. More of those negatively charged proteins would be found on the inside of the cell. And here you can see intracellular versus blood plasma and the relative concentrations of the different types of ions. So now we're going to talk about individual electrolytes and then what happens if you have too many or too few of each one of those. So sodium. Sodium is important for electrical signaling in nerve and muscle cells. It contributes to the rusting membrane potential. An inflow of sodium through ion channels is essential to depolarizations that underlie nerve and muscle function. Sodium ions bound to the proteoglycans of cartilage retain water, ensuring cartilages are well hydrated. They're the principal cation in extracellular fluid. Sodium salts account for 90 to 95% of osmolarity in the extracellular fluid, most significant solute in determining total body water and distribution of water amongst fluid compartments. Sodium gradient is a source of potential energy for co-transport of other solutes, such as the sodium-potassium pump. It's an important means of generating body heat, and sodium bicarbonate has a major role in buffering pH in the extracellular fluid. Adult needs about 0.5 grams of sodium per day, but the typical American diet contains 3 to 7 grams per day. The primary concern is excretion of excess dietary sodium. Aldosterone plays the primary role in adjusting sodium excretion. Hyponatremia and hyperkalemia directly stimulate the adrenal cortex to secrete aldosterone. Hyponatremia. So hypo means less, hyper means more. Na is the chemical symbol for sodium, Na. So hyponatremia is having not enough sodium. Hyperkalemia, the K is for potassium, that means you have too much potassium. Hypotension stimulates the secretion by the way of the renin-angiotensin-aldosterone mechanism. Aldosterone stimulates reabsorption of sodium, secretion of potassium. Because water follows sodium osmotically, plasma sodium concentration is relatively unchanged. And here's a diagram that shows the action of aldosterone. Antidiuretic hormone modifies water excretion independent of sodium excretion. High sodium in the blood stimulates the posterior pituitary to release ADH. Kidneys reabsorb more water, slows further increase in blood sodium concentration. Natriuretic peptides inhibit sodium reabsorption, so the kidneys eliminate more sodium and water is lost. Other hormones, estrogen mimics aldosterone. Progesterone has a natriuretic effect, so sodium is excreted and water is lost. And glucocorticoids, sodium is reabsorbed, and then you have fluid retention and possible edema. Sodium imbalances, hypernatremia, plasma sodium concentration greater than 145 millieq per liter from administration of IV saline, water retention, hypertension, and edema. Hyponatremia, plasma sodium concentration is less than 130. Person loses large volumes of sweat or urine, replacing it with drinking plain water, or if you happen to get fluids at a hospital and get distilled water as a fluid, that would be another source. It results in excess body water, quickly corrected by the excretion of the excess water. Potassium. Potassium is involved in electrical signaling in nerve and muscle cells, resting membrane potential, repolarization, and hyperpolarization of the action potential. It's the most abundant cation of the intracellular fluid, the greatest determinant of intracellular osmolarity and cell volume. Sodium-potassium pumps sodium on one side and potassium onto the other. It's an essential cofactor for protein synthesis and other processes. It's closely linked to sodium homeostasis. 90% of potassium in the glomerular filtrate is reabsorbed by the primary convoluted tubule. Distal collecting tubule and the cortical portion of the collecting duct secrete varying amounts of potassium in response to blood levels. Aldosterone stimulates renal secretion of potassium. Because aldosterone causes sodium to come in, potassium has to go out. Most dangerous types of electrolyte imbalances involve potassium. Hyperkalemia, plasma potassium concentration is high. Effects depend on how fast the potassium concentration rises. So since potassium is supposed to be inside of your cells, if your cells break open, you're going to see a spike in potassium levels. When we do blood work in a clinical lab, if we get a blood specimen and the blood specimen, we spun it down so that the red blood cells are on the bottom and then the plasma or serum is on the top, and we see that the plasma or serum is red, that means that our red blood cells have ruptured, releasing the hemoglobin, which has that red pigment, into the plasma. If our red blood cells are ruptured, it's called hemolysis, then we would expect to see high levels of potassium. Now, if you run the blood and you don't know that little fact that, hey, red blood is going to give you or red plasma / serum is going to give you a falsely elevated level of potassium, you may be reporting an urgent or critical result to a doctor when really it's not. It's just because of the massive hemolysis. So, hyperkalemia, like I mentioned, effects depend on how fast the potassium concentration rises. If extracellular concentration rises quickly, crush injury, depolarized resting membrane potential makes neurons and muscle cells more excitable, can produce cardiac arrest. If slow onset, gradually rising membrane potential inactivates voltage-gated sodium channels, neurons and muscle cells become less excitable. They use, or used to use, pretty sure they still do, an injection of potassium to stop the heart, particularly in euthanasia. Hypokalemia, plasma potassium concentration is less than 3.5, rarely results from a dietary deficiency. It's usually from sweating, chronic vomiting, diarrhea, excessive lactate use, aldosterone hypersecretion, or alkalosis. Nerve and muscle cells are less excitable, muscle weakness, loss of muscle tone, decreased reflexes, and arrhythmias from irregular electrical activity in the heart. Here's a diagram that you can go ahead and pause the video and read through what's going on in each one of these areas. Calcium. Cells maintain very low intracellular calcium levels to prevent calcium phosphate crystal precipitation. Phosphate levels are high in the intracellular fluid. Cells have to pump out calcium though. Calsequestrin is a protein that binds that calcium that got pumped out and keeps it unreactive in the smooth endoplasmic reticulum, releasing it when needed. It keeps intracellular calcium levels low, or it sequesters it. It's chiefly regulated by parathyroid hormone calcitrol, or vitamin D, and calcitonin in children. These hormones affect bone deposit and resorption, intestinal absorption, and urinary excretion. Hypercalcemia, plasma calcium greater than 5.8. Causes would be alkalosis, hyperparathyroidism, hypothyroidism, reduces membrane sodium permeability, and inhibits depolarization of nerve and muscle cells. Concentrations greater than 12 cause muscular weakness, depressed reflexes, and cardiac arrhythmias. Hypocalcemia, plasma calcium less than 4.5, causes vitamin D deficiency, diarrhea, pregnancy, acidosis, lactation, hypoparathyroidism, hyperthyroidism, increased membrane sodium permeability, causing nervous and muscular systems to be abnormally excitable. Very low levels result in tetany, laryngospasm, and death. Chloride, most abundant anion in the extracellular fluid. Major contribution to extracellular fluid osmolarity. Required for the formation of stomach acid. Chloride shift that accompanies carbon dioxide loading and unloading in the red blood cells. Major role in regulating body pH. Homeostasis is primarily achieved as an effect of sodium homeostasis. It has a strong attraction to sodium, potassium, and calcium, which chloride passively follows. As sodium is retained, more chloride is retained. Chloride imbalances. Hypochloremia is a side effect of hyponatremia, sometimes from hyperkalemia or acidosis. Hyperchloremia is a result of dietary excess or administration of IV saline. Phosphates. So inorganic phosphates of the body fluids are in an equilibrium mixture of monohydrogen phosphate and dihydrogen phosphate, relatively concentrated in intracellular fluid due to the hydrolysis of ATP and other phosphate compounds. Every process that depends on ATP depends on phosphate ions. The metabolic pathway is phosphorylation of enzymes and substrates, component of some buffers that stabilize the pH of body fluids. Phosphates make up a portion of the backbone, the DNA backbone of our DNA. So they're an integral part of everything that we need to do to stay alive. Normally, phosphate is continually lost by glomerular filtration. If plasma concentration drops, renal tubules reabsorb all filtered phosphate. Parathyroid hormone increases excretion of phosphate, which increases concentration of free calcium in the extracellular fluid. Lowering the ECF concentration of phosphate minimizes the formation of calcium phosphate and helps support plasma calcium concentration. Phosphate imbalances are not as critical as other electrolytes. The body can tolerate broad variations in phosphate concentration. Acid-base balance, a state in which the pH of the body fluids is maintained within normal homeostatic limits. 7.35 to 7.45. You need to have that range memorized. You need to know what the normal range of the pH of body fluids is. The pH of a solution is determined by its hydrogen ions. An acid is any chemical that releases hydrogen ions in solution. Strong acid ionizes freely, giving up most of its hydrogen ions and markedly lowers the pH. For example, hydrochloric acid. A weak acid ionizes only slightly. It keeps most hydrogen in chemically bound form that does not affect the pH. For example, carbonic acid. A base is any chemical that accepts a hydrogen. A strong base has a strong tendency to bind hydrogen and raise the pH. For example, the hydroxide ion. A weak base binds less of the available hydrogen and has less effect on pH. For example, the bicarbonate ion. Buffer, any mechanism that resists the pH changes by converting a strong acid or base to a weak one. The body has both physiological and chemical buffers. Physiological buffer is a system that stabilizes pH by controlling the body's output of acids, bases, or carbon dioxide. The urinary system buffers the greatest quantity of acid or base, but takes several hours to days to exert its effect. The respiratory system buffers within minutes, but cannot alter pH as much as the urinary system. Chemical buffer, a substance that binds hydrogen ions and removes it from solution as the concentration begins to rise, or releases hydrogen ions into solution as the concentration falls. It restores normal pH in fractions of a second. Buffer systems are mixtures composed of weak acids and weak bases, and there's three major chemical buffers: the bicarbonate, phosphate, and protein systems in the body. The amount of acid or base neutralized depends on the concentration of the buffers and the pH of the working environment. Each buffer system has an optimum pH at which it functions best. The bicarbonate buffer system is the solution of carbonic acid and bicarbonate ions. Carbonic acid and the bicarbonate ions participate in a reversible reaction. The direction of the reaction determines whether it raises or lowers pH. So if we have carbon dioxide plus water, which gets converted to carbonic acid, which then releases a hydrogen and gets converted to hydrogen and bicarbonate, it's going to lower the pH because it has released the hydrogen. Now, if it accepts the hydrogen and converts to carbonic acid and then eventually water and carbon dioxide, it increases the pH because it's removing the available hydrogen from the environment. We talked briefly about this when we talked about the respiratory system. Physiological and chemical buffers of the body function together in maintaining the acid-base balance. So the bicarbonate buffer system has an optimum pH of 6.1, too low to neutralize acid well at a pH of 7.4. In the body, bicarbonate buffer system works because the lungs and kidneys constantly remove carbon dioxide and prevent equilibrium from being reached. It keeps the reaction moving to the left, neutralizing the acid. To lower pH, kidneys excrete bicarbonate and keep the reaction moving to the right, elevating the hydrogen concentration in the extracellular fluid. Phosphate buffer system is a solution of phosphate or monohydrogen phosphate and dihydrogen phosphate. Dihydrogen phosphate can be converted to monohydrogen phosphate and a free hydrogen. Depending on the direction it goes, it can either donate a hydrogen to reduce the pH, or it can accept a hydrogen to increase the pH. Important buffering in the intracellular fluid and renal tubules. In these places, phosphates are more concentrated and the buffer can function closer to its optimum pH of 6.8. Constant production of metabolic acids creates pH values from 4.5 to 7.4 in the intracellular fluid, an average of 7. Then we have the protein buffer system. Proteins act as buffers due to the side groups of their amino acids. The protein buffer system accounts for about 3/4 of all chemical buffering in the body fluids. Proteins are more concentrated than bicarbonate or phosphate systems, especially in the intracellular fluid. Example side groups with the ability to buffer pH: the carboxyl group, COOH, it can release hydrogen when the pH begins to rise. Amino groups, NH2, can accept a hydrogen when the pH begins to drop. The respiratory buffer system adjusts pH by changing the rate and depth of breathing. The bicarbonate buffer system is the basis for the strong buffering capacity of the respiratory system. The addition of carbon dioxide to body fluids raises the hydrogen concentration and lowers the pH. The removal of carbon dioxide has the opposite effect. It can neutralize 2 or 3 times as much acid as the chemical buffers can. Carbon dioxide is constantly produced by aerobic metabolism and normally eliminated by the lungs at an equivalent rate. So carbon dioxide from metabolism from water is converted to carbonic acid and then bicarbonate and hydrogen, which lowers the pH. If we go in the reverse direction, it raises the pH by binding hydrogen. Increased carbon dioxide and decreased pH stimulate chemoreceptors, which stimulate increased pulmonary ventilation to expel carbon dioxide and raise the pH to normal. An increased pH reduces pulmonary ventilation, allows metabolic carbon dioxide to accumulate and lower the pH to normal. The kidneys can neutralize more acid or base than either the respiratory system or chemical buffers. They vary the amount of acid eliminated in the urine. The renal tubules secrete hydrogen ions into the tubular fluid. Most binds to bicarbonate, ammonia, and phosphate buffers. Bound and free hydrogen are excreted in the urine, actually expelling hydrogen ions from the body. Other buffer systems only reduce its concentration by binding it to other chemicals, while the urinary system can actually secrete it from the body. This is a diagram that goes through the secretion and neutralization of hydrogen ions in the kidneys. I recommend that you pause the video and take a look at what's all going on in this diagram. The phosphate system, dibasic sodium phosphate, is contained in the glomerular filtrate. It reacts with some of the hydrogen in the buffer, which passes into the urine. Ammonia, from amino acid catabolism, acts as a base to neutralize acid. Here's another diagram, acid buffering in the urine. Disorders of the acid-base balance. Acidosis is a pH of the extracellular fluid below 7.35. Hydrogen diffuses into the cells and drives out potassium, elevating potassium concentration in extracellular fluid. Hydrogen buffered by protein in the intracellular fluid, so the net result is cation loss. This causes membrane hyperpolarization. Nerve and muscle cells are hard to stimulate. CNS depression may lead to confusion, disorientation, coma, and possibly death. Alkalosis, when we have a pH of extracellular fluid above 7.45, hydrogen diffuses out of cells and potassium diffuses in. Membranes depolarize, nerves are overstimulated, muscle causes spasms, tetany, convulsions, respiratory paralysis. A person cannot live for more than a few hours if the blood pH is below 7 or above 7.7. And here's that scale. And here's a diagram of acid-base balances and potassium balances. Acid-base imbalances can be respiratory or metabolic in cause. Respiratory acidosis occurs when the rate of alveolar ventilation fails to keep pace with the body's rate of carbon dioxide production. Carbon dioxide accumulates in the extracellular fluid and lowers its pH. It occurs in emphysema, where there's a severe reduction of functional alveoli. To compensate for respiratory acidosis, since your respiratory system isn't working right, your metabolic compensation is going to take over. So your urinary system is going to start secreting more of the acid into the urine. Respiratory alkalosis results from hyperventilation. Carbon dioxide is eliminated faster than it's produced. In this case, it's going to be compensated for by metabolic processes. Your urinary system is going to reabsorb more hydrogen ions to neutralize the pH back to normal. Metabolic acidosis is when you have an increased production of organic acids such as lactic acid in anaerobic fermentation and ketone bodies as seen in alcoholism and diabetes mellitus. Ingestion of acidic drugs like aspirin, loss of base due to chronic diarrhea or laxative overuse. Metabolic alkalosis, rare, but can result from overuse of bicarbonates, antacids, and IV bicarbonate solutions, or loss of stomach acid, chronic vomiting. Compensated acidosis or alkalosis, either the kidneys compensate for the pH imbalances of respiratory origin, or the respiratory system compensates for the pH imbalances of metabolic origin. Uncompensated acidosis or alkalosis, a pH imbalance that the body cannot correct without clinical intervention. Respiratory compensation, so changes in pulmonary ventilation to correct changes in pH of body fluids by expelling or retaining carbon dioxide. Hypercapnia, excess carbon dioxide, stimulates pulmonary ventilation, eliminating carbon dioxide and allowing the pH to rise. Hypocapnia, or deficiency of carbon dioxide, reduces ventilation and allows carbon dioxide to accumulate, thereby lowering pH. Renal compensation, I already kind of alluded to this. The pH is adjusted by changing the rate of hydrogen secretion in the kidneys. It's relatively slow, but better at restoring a fully normal pH. In acidosis, urine pH may drop to 4.5 due to excess hydrogen ions. In alkalosis, urine pH may go as high as 8.2 due to excess bicarbonate ions. The kidneys cannot act quickly enough to compensate for short-term pH imbalances. Fluid replacement therapy. So restoring and maintaining proper fluid volume, composition, and distribution is a significant problem in the treatment of seriously ill patients. Fluids may be administered to replenish total body water, restore blood volume and pressure, shift water from one fluid compartment to another, or restore and maintain electrolyte and acid-base balance. Drinking water is the simplest method, but water alone does not replace electrolytes. For patients who can't take by mouth, fluids may be given by enema or parenteral routes, fluid administration other than the digestive tract. So IV route is most common. There's subcutaneous, intramuscular, or other parenteral routes. Excessive blood loss is sometimes countered by quickly giving normal saline. Rises blood volume while maintaining normal osmolarity. Requires a very large volume to be given because much of the saline escapes the blood and enters the interstitial fluid compartment. It can induce hypernatremia or hyperchloremia, but it can be used to correct pH imbalances as well. Acidosis is treated with Ringer's lactate solution. Alkalosis is treated with potassium chloride. Plasma volume expanders, hypertrophic solutions or colloids that are retained in the bloodstream and draw interstitial water into it by osmosis. Used to combat hypotonic hydration by drawing water out of swollen cells. It can draw several liters of water out of the intracellular fluid within a few minutes. For patients who can't eat, they may be given isotonic dextrose solution. Fasting patients lose as much as 70 to 85 grams of protein per day. IV glucose reduces this by half, so it has a protein-sparing effect. For patients with renal insufficiency, it's given slowly through IV drip, since the kidneys might not excrete water fast enough.